Welcome, everyone. On behalf of React 19, I am happy to introduce Dr. Yusuf Saleeby, who will be speaking to us today on new treatments for vaccine injuries. Dr. Saleeby is an integrative medicine physician. He is a contributor to the FLCCC I Recover protocol for post-vaccine syndrome. For almost 2 decades, he pursued a career in emergency medicine, occupational medicine, urgent care, and family medicine. He retired from traditional mainstream medicine in 2013 and currently practices integrative and functional medicine at Carolina Holistic Medicine, where he serves as medical director. He is a featured speaker on nutrition and adaptogen herbs and has contributed numerous books and chapters. Please welcome Dr. Saleeby.
Thank you, Denise, for that introduction. Okay, I will share my slides for the presentation today. And I thought there's so many things going on with, let's see if I can get that to start. Okay, there's so many things going on with the treatment, such an evolving situation with new things in the pipeline and old things being rediscovered or repurposed. So one of the biggest things that is of benefit to people is intermittent fasting or some kind of fast, whether it's a partial water fast or a straight full day fast. Seems to trigger or flip the switch for autophagy on to clean up your cells, and mitophagy to clean up the mitochondria as well, which are very sensitive to insult from the spike protein. So there are, for many reasons, people who just shouldn't fast or intermittent fast, or who can't comply with what the doctor orders. So there are a few little tricks that I'm going to talk about that may be helpful for those that find it difficult to do any type of intermittent fasting. And this presentation was done previously, so I have some teaching points here. The introduction, I'll go briefly through my financial and evidence-based medicine disclosures, as I do with all my lectures these days. And then we'll define fasting mimetics, and we'll talk about some agents, both pharma and natural, and some of the benefits, and then summarize. Now, I will kind of pass through some of these slides quickly because some of it is pretty technical, and I'll try to keep it very clinically oriented and not too much of the basic science, but I will pass on the slides and hang out there for a minute or two, just in case anyone wants to go back and look at this recording again. They can pause it, and then they can dive deep and read some of the texts or go to some of the links. So I have nothing to disclose financially, and I always include, for the last several years, even pre-pandemic, I've included evidence-based medicine disclosures because sometimes we can't trust what's in our literature. And here are a few links you can take to read about it, either from the journals themselves or from interviews with some ex-editors about their journals. So fasting mimetics or caloric restriction mimetics, used interchangeably, are bioactive compounds that mimic fasting or intermittent fasting and their effects. They are a growing interest in anti-aging movement, and they have been for many years. Even pre-pandemic or vaccine. They may also be useful as a tool in detoxifying ourselves or our bodies and getting rid of the S-spike protein, or what we refer to as the spikeopathy issues, for those who are intolerant of intermittent fasting. So before we get involved in what autophagy is and why intermittent fasting might be helpful, or fasting mimetics might be helpful, is that if you look at aging as a disease state, you have loss of quality of life. There's usually an increase in blood pressure as we age. Inflammatory markers, biomarkers, usually go up. There is a disruption of insulin signaling. There's also a defective part of protein acylation, and the CVD, cardiovascular disease, risk parameters go up. Sirtuin activity declines, and we'll talk a little bit about sirtuins and what they do. So with caloric restricting or fasting, and this is also mimicked by the fasting mimetic agents and drugs, you see some physiological effects and molecular effects too. We'll go over those. With physiological effects, you see an increase in quality of life, weight loss, metabolic adaptation, core body temperatures can go down, blood pressures can go down, some of your inflammatory biomarkers can go down in levels, fasting insulin levels will drop, and energy expenditures will also drop. Now, on a molecular level, there's a reduction in oxidative stress, nutrient signaling, thyroid axis activity, tumor necrosis factor alpha declines, and your cardiovascular disease parameters decline. Autophagy, or autophagy, some people pronounce it, goes up, and that's the kind of thing that cleans up the cells. AMPK goes up, and that's a pathway, we'll talk about that briefly, and mTOR goes down. Sirtuin activity goes up, and you have modulation of some protein acetylation. And that usually improves health span and longevity. Now, this is a complicated slide, and I'm just going to put it up here for just a sec, just to focus on a few things. You see in red resveratrol. You see also on the right-hand side spermidine and some salicylates, of which aspirin is one, although we try to stay away from that because of bleed risk. But those are all things that have an impact on AMPK pathway, which leads to eventually to autophagia or autophagy. There are berberine, that was a favorite topic on the FLCCC recently with Dr. Paul Merrick and his work using berberine to control type 2 diabetes. You have nicotinic riboside, NMN, EGCG, which is an extract of green tea or black tea, and quercetin. Those all have an impact on the KDAC or sirtuins that also lead eventually to autophagy. And then at the very bottom right-hand corner, you see rapamycin. That is an agent, and that discovery of that compound first discovered on Easter Island, and so named after the native people's name for Easter Island, which is Rapamune, Rapamune. So mTOR is the mammalian target of rapamycin. So the discovery of rapamycin led to the discovery of mTOR, and that also has a big part to play in autophagy. So we'll talk about caloric restriction mimetics or fasting mimetics. So the periodic reduction in caloric intake without going into malnutrition, in other words, without starving yourself, but just limiting your caloric intake, is a main strategy that is reliable and has been proven in many studies, both in animals and in humans, to help increase lifespan. It's not necessarily a very comfortable way to do it. You have to really restrict diet where you're almost kind of constantly hungry all the time. But if you can stick to a strict and lifelong compliance with intermittent fasting or with caloric restriction, it can lead to increased lifespan and health span. But for those that can't, because it's very difficult to fast all the time, so you may have to cycle it or do it a few days during the week. Any little bit during the week will help. It's not an all or nothing thing, actually. There are some tricks to use. So on the days that you're not fasting, you may want to implement some of these agents to control the things we talked about that are significant in your path to autophagy. We're going to discuss some medications and supplements and also classes of sirtuins. Sirtuins are known as enzymes that interfere with mitochondrial energy metabolism and molecular pathways involving longevity. And here's a bit more detail. This is more of a scientific dive into sirtuins, SRT1 through 7. There's 7 known. There are probably going to be more discovered. But some of them will protect us and with endothelial function, metabolic syndromes, ischemia, obesity, and some sirturins class 3 protect against lipids that go crazy and ischemic reperfusion injuries. So there's a lot to it on this slide. If you want to come back to this and read through all the text, you can. I'm not going to read the entire thing. And I'm definitely not going to read this out to you. This is a pretty complicated pathway, but you actually can see mTOR in there circled a couple of times. And there's actually mTOR complex 1 and complex 2. So even within mTOR, it gets broken down in two parts. But these all have regulation of transcription and metabolism and autophagy within the cell, and involved in cell death as well. I'm going to kind of just briefly go over this. Maybe if I just skip over it, really, you can come back and read these 3 paragraphs later. It further explains AMPK and mTOR and how they play a role. But what we're really here for is to talk about what these agents are. And so I'm going to enumerate the ones that affect sirturins medication-wise, and then we'll talk about some of the supplements. So metformin, or glucophage, is probably best known for its use in treating type 2 diabetics. It's one of the most prescribed anti-diabetes drugs, if you will. It has an interesting action in that it has a hormone effect, so they do use it in fertility work. Some fertility clinics use it to help with conception or conceiving. It's also used in women with PCOS, polycystic ovary disease, where their testosterone are too high. So this drug actually acts as a little bit of a hormone modulator. It's a very interesting compound, and if you take it in low forms and you have to watch vitamin B12, and you have to watch the gut microbiota, because it can have a negative effect on both of those. So just some people who take metformin at higher doses or for long terms have to take supplement with B12. Rapamycin, which actually had its first life as an antifungal, and then later was discontinued for that because its immune effects, it kind of knocked down the immune system. Later kind of came popular again during transplants, specifically organ transplants like the kidney. So to keep the recipient from rejecting a donor kidney, rapamycin was one of several drugs used as an anti-rejection agent. In recent years, in the last 5 to 10 years, low-dose rapamycin is being used in anti-aging purposes as a weekly drug, taken weekly. And there's a protocol for acute COVID infections where you front load a dose of rapamycin, usually 5 or 6 milligrams, followed by about 2 milligrams a day for 8 to 10 more days. In long haulers and vax injured, we're looking at using rapamycin in a dose of about 5 to 6 milligrams weekly to help modulate that disease. Kind of, it's one of the newer agents, rapamycin, like methylene blue, like a few others. Aspirin will also do it, or any salicylate, but again, you have concerns over erosion of the gut and bleed risk. Excuse me. There are some other agents here. I'm not going to read them all out, and some of these are still in the pipeline or experimental, especially the ones like SRT-172, which is not FDA approved yet, but in clinical trials. These are all agents that are used, that are synthetic medications that are used as fasting mimetics. Now I'll talk about some of the dietary supplements or nutraceuticals. So nicotinamide adenine dinucleotide, or nicotide riboside, which is called NR for short, and the other one is called NMN, are agents that are used in anti-aging and also mimic fasting. Resveratrol is a polyphenol found in many plants, and a lot of people may remember reading about it years ago as something that may have been part of the French paradox, like why do the French eat a lot of fatty foods? Well, they drink a lot of wine, which has resveratrol in it, so maybe that counter the effect of the quote-unquote bad fats in their diet, and that's why they don't have heart disease. Resveratrol is a great agent. I use it a lot in my Lyme patients because it helps with Herxheimer reactions, suppressing those. It's a biofilm disruptor, and it's also useful in the treatment of Lyme spirochetes. So resveratrol, also called RES, R-E-S for short, polygonum, Japanese knotweed are also names used for agents that things that contain resveratrol. Curcumin, you're probably very familiar with. Curcumin from the Curcumin oolonga tuber is used in Ayurvedic and Indian medicine for many, many years, has many properties as an anti-inflammatory, also happens to be a fasting mimetic. Same can be said for quercetin, that's found in some of the citrus fruit skins and onions in nature, but in supplement form you can find it. That again was on the FLCCC protocol as a chief agent amongst a few others for acute COVID. And then spermidine, which is found in oats and wheat products. In nature, you have to eat a lot of wheat germ to get it. There are some companies that purify it and actually make a version that's actually gluten-free. It's a polyamine, and it helps with attacking spike. It actually helps detoxify spike, as well as being a fasting mimetic. Hinokiol, which is an extract of the magnolia tree bark, is another agent. We use that in cancer protocols and in sleep protocols for people with insomnia. And there are a couple of others that are mentioned here. NMN is a great one for enhancing NAD or NAD plus in circulation instead of going and getting those expensive long IVs. It's a niacin. It's in the family of niacin or B3. There's EGCG, which is, again, I mentioned earlier, is an extract of tea, black tea and green tea, and that also acts as a fasting mimetic. There you see NAD plus, but that's very unstable, degrades very quickly, so you have to give that IV, and usually the infusions can be quite lengthy, up to 6 hours, in some cases where they use them in recovering alcoholics and those with cognitive decline. So it might be easier to take things like NR or NMN in place of the IV NAD and let your body kind of create its own. And then you see things like berberine. There are many plants that have berberine in it, so it's not just coming from one plant. This nutraceutical can come from very many different plants. It is very, very bitter, and it's yellow, almost as yellow as curcumin, and has a lot of uses. It's used in treating people with dyslipidemia or lipid disorders, cholesterol disorders. It's used to treat folks with type 2 diabetes, but it's also used as an antimicrobial agent. It kills a lot of organisms, usually leaving the good ones alone and killing the bad ones. So it's good for people who have abnormal overgrowths of gut microbiome. And then you have a whole class of peptides. There's hundreds of peptides out there that are called healing peptides. Peptides, you all probably know or familiar with insulin. Insulin's a peptide, so is growth hormone. They're usually very short chain amino acids. If they get too long, they tend to, these are linear, they tend to kind of curve in on themselves and become three-dimensional. And then we call those things proteins. But if they stay sort of linear, and some peptides are healing peptides are very short, they're only 3 amino acid base long. Some are a bit longer. Thymosin alpha 1 coming from the thymus gland, which as we get older starts to disappear, and usually by our teen years there's not much left. So thymosin alpha 1 was very helpful in COVID lung. These are people who were admitted for hospitalization because of a COVID infection, and they went and spent a month in the ICU, and their lungs were all beat up when they came out. Well, as an outpatient, they were giving thymosin alpha 1, and there have been many reported cases of that healing their damaged lung. So much so that the FDA stepped in, and I want to say around March of 2021, and banned the use of it by compounding pharmacies and physicians. So we had to find workarounds to get this to our patients. Thymosin B1 beta 1. BPC 157 is a very popular one. It's gut stable, so you can take it orally. The first two mentioned there are usually best given subcutaneously by injection, just like you would give insulin. But BPC 157 is derived from the gut of laboratory animals. That's where it was discovered, so it's gut stable. So is TB 500 or TB 4 frag, which is also synonymous with that. So these are a list of nutraceuticals you don't need prescriptions for but you do need guidance. I wouldn't say do it yourself kind of thing. Just go out and grab some of these off the shelf and take it. You need some guidance by a clinician who knows how to manage this so that they are effective and you don't get in trouble with them. So the benefits of taking these, either the pharmaceuticals or the nutraceuticals, is to, autophagy, cleaning up the cell and promoting healthy organelles. Those are little components that are within the cell. So like, for instance, the mitochondria is an organelle that resides within the cell, so that we can have better function and longer life of each cell. Autophagy provides a higher functioning cell and cell life. Then you have mitophagy, which is the same thing, but in the mitochondria. Like autophagy in the cell, regarding the cell in general, and multiple organelles, the mitophagy focuses on cleaning up the mitochondria, which is the powerhouse of the cell. So the mitochondria is responsible through the Krebs cycle to create ATP, which is the energy for the cell, and electron chain processing. So you have a healthy mitochondria, you have a healthy cell, you have a healthy person, healthy body. And then, of course, its uses in anti-aging go back many years to the anti-aging movement and restorative medicine movement for regeneration and cell health. Restorative medicine practitioners use adjuncts to lifestyle modifications, exercise, good diet and nutrition, all on all different fronts, and they all utilize some of these agents, both prescriptive and natural. So here's the priority of how you'd want to do this. And obviously, intermittent fasting is free, doesn't cost anything, and has very few side effects, other than for maybe in the beginning a few hunger pains. But you sort of get used to it, and you sort of start with, maybe don't eat anything after 8 at night, and then resume eating at 12 noon or even 11. Do that for a week or so, and then you go and maybe don't eat anything after 6 p.m. and stretch it out to maybe 1 o'clock in the afternoon, and that's your fasting. And again, you don't have to do this every day, but maybe do it 5 days out of the week. Obviously, the more you do it, the longer you do it, the more beneficial effect you have. But it's variable, and maybe sustainability is an issue. So then my next step would be to go to some natural agents. I would do the natural ones first, because they're pretty effective and they're least likely to have any adverse side effects. And if those don't work, I will then go to the pharmaceutical ones. And again, these are not all mutually exclusive. You can do a little intermittent fasting and use a couple natural agents. Or, if you want to take a break from fasting, you can do some of the natural and pharmaceutical agents. So it's a kind of a mix and match for many people, and it's very individualized. The last thing you want to do is, if you have a good clinician using some biomarkers, they can assess these certain matrices. So biological aging, markers of aging, telomere length. The telomeres are the tips of the chromosomes, the very tips, the end caps. Think of a long shoelace and that little plastic part at the end. That's the telomere. And if you can keep the length of that nice and long, you'll be able to replicate that DNA, that chromosome. If every time the enzymes come on to replicate it, it shortens the telomeres a little bit. And after a process, it used to be known as the Hayflick limit, but now we know we can go beyond that. There was a limit, there was around 60 or 68 times that the chromosomes could be replicated for creating new cells. And Dr. Hayflick was the one that discovered that limit. But now we've crossed beyond that. We've crossed over that, and we can say now that we can bypass or skip over the Hayflick limit by certain agents or andrographis or astragalus and things like that. Some adaptogen herbs can lengthen that, keep them nice and long. Healthy lifestyle, not smoking, not drinking, those will shorten your telomeres. But that's one of the biomarkers you can use. Genomics and epigenetic markers. There's a company out of Georgia called Genfinity. They have a series of biomarkers for longevity, but they're extremely expensive. But you can run a panel and kind of come up with your biological age, not your chronological age. And then there is a test called ID30 that identifies 30 different autoimmune diseases. That might be very helpful in looking at folks that are vaccine-injured who are susceptible or already have one or two autoimmune diseases. This will identify several more. And there's a new one, it's called the MitoSwab. As a matter of fact, today I sent out mine. It's a buccal swab. So you do 4 swabs on the inside of your cheek. You put it in a Eppendorf tube and then put it on ice and send it out to the company. And there we'll look at some aspects of complex 1 and complex 4. So there's complex 1, 2, 3, and 4 in the mitochondria, in the sort of the wall of the mitochondria, if you will. There are that where ATP production is made. So knowing your activity of complex 1 and 4 are very important. So MitoSwab is another one that costs, I think, around $300 or $400 for that test. That's something your provider, if he understands that, could order on you. So in summary, while fasting or intermittent fasting and caloric restriction are maybe the best and cheapest way for anti-aging and for autophagy, mitophagy, it is not always possible or practical. Somebody with thyroid disease, for instance, it may be harmful to their thyroid to do too much intermittent fasting. A woman who's pregnant or nursing, again, fasting or intermittent fasting may be contraindicated. So, and then there's people who can't adhere to things. They have a problem with compliance or adherence to recommended interventions. So there's several, as mentioned above, several synthetic and natural agents that can mimic intermittent fasting or fasting and hold similar properties and outcomes. I'll just touch briefly on some agents that we discussed at the FLCCC medical conference and have made their way into some of the protocols for vaccine injured and long haulers, and one is methylene blue. You have to use pharmaceutical grade. There's 4 different grades of it. You don't want to be using the industrial grade as an industrial dye because it may be contaminated with heavy metals. So you can also get these compounded by a compounding pharmacy with pure USP grade agents. You can also get methylene blue from the BPH company, where you can see it says 1% methylene blue USP grade. So that's pharmaceutical grade. It's very messy, comes in a dropper. If you get it on anything, it'll stain it blue almost permanently. And again, don't do it yourself. There's books out there that tell you how to do it, but there's some caveats. You cannot take this agent if you're on an SSRI or SNRI. You should not take it if you're pregnant or nursing. You should not take this if you're known to have G6PD deficiencies, because it may lyse your cells. And there's some caveats here that an experienced practitioner should know about to guide you through on how to use methylene blue. Most people have probably heard of NAC, N-acetylcysteine, but there's an augmented or optimized NAC. It is imported in from Italy, and Scott Marsland, who's Pierre Corey's partner and nurse practitioner in that practice, clued me in on this. He said that within taking this after a few days, he noticed quite a difference himself. So augmented NAC available through a compounding pharmacy called Vita Health Apothecary in New York State. You can go to their website. You can either e-commerce order it or call them. They're, to this day, and we're in May of 2023, at this point, the only importers in this country of this. It's basically a very high grade good bioavailability of N-acetylcysteine. With lesser versions of NAC, you run the risk of opening up the bottle, and even before you're halfway through, it degrades and oxidizes. So buy small quantities of any kind of NAC because it does degrade. Another drug we mentioned at the conference for neuro COVID or neuro post-acute sequela of COVID is Mementine. Brand name is Namenda. Mementine is an old Alzheimer's disease drug. Goes back as long as, I think, the first year I practiced integrative medicine. This was almost 20 some years ago. I was probably one of the first doctors to prescribe Mementine. It was not even FDA approved. I had a very desperate patient who begged me to get it. He had read an article out of Germany where it was manufactured and had brought that piece of article, published article in and said, hey, can you get me this drug? I said, I don't know if I can. It's not even FDA approved. I've never even heard of it before. So I had to petition the FDA and they granted me permission to go to the manufacturer to see if I can't get some for this patient. And they were so generous and kind, they actually sent a big cardboard box full of many sample bottles for free for this patient who suffered from really rapid Alzheimer's disease. I don't know that it worked very well for Alzheimer's. I don't think any of the pharmaceuticals work too great for Alzheimer's disease, but this mechanism of action of this particular drug tends to put the fire out that's in the brain when we talk about neuroinflammation. A lot of people have neurological symptoms from being vaccine injured, and we now have quite a number of patients in our practice who are on Mementine. We start kind of low, usually around 2.5 to 5 milligrams, and we do it for maybe 3 months. And then we transition them to some other agents, something like Butterbur extract, that mimics this. But the traditional dose of Namenda for an Alzheimer's patient is 10 milligrams twice a day. So we're using much lower doses and we titrate up. Sometimes we'll go up to 5 milligrams. Most of the time we start out with 2.5. I think Scott starts his patients out even lower, 1.25 milligrams. But anyway, this is a newer thing. It's evolving. We're going to see how well it works with some of our neurological COVID patients. And then just a little plug here for our center. We have 2 locations in South Carolina, carolinaholisticmedicine.com for more information. We have opened up the COVID Illness Recovery Center. And the reason we call it COVID illness is that we cover everything from acute, long haulers, and post-acute sequela of COVID at our center. And we also try to dig for things underlying that cause people to stall out in their recovery or plateau. So if you're plateauing out, our center can sometimes come to the rescue to get over that hump, to get good healing. Okay, for folks interested in rapamycin and mTOR and oxytocin that comes in a nasal spray or sublingual application, there's lots of good things, even metformin. We have the Priority Health Academy library in our blog and some of our social media pages. We post things on rapamycin, methylene blue, mTOR. So if you're interested, you can visit those sites. And this is how to get a hold of me. We have the priorityhealth.us is the academy for more of our functional medicine education and our clinical practice. Now we do have a special COVID site at www.saleeby.net/COVID. And there's more information, and that's kind of the place of entry for people that are vaccine injured or have long haulers if they wish to be seen. We do a lot of telemed. We are, me and 3 of my practitioners are all licensed in a way to treat people in all 50 states. I take on some Canadians and from people from overseas. So there, I'll leave this up for a bit. And okay. And it looks like, let me check the chat box and see what's going on here.
I wrote down a few questions if you want me to.
Sure. Sure thing.
First of all, do PPIs interfere with autophagy.
I'm assuming they're talking about proton pump inhibitors.
Right.
One of my least favorite drugs. I don't know a direct answer to that, but they interfere with a lot of good things biologically that are going on. They're very disruptive of the microbiome. They disrupt absorption of iron and certain other minerals and vitamins, especially B vitamins, since they do lower the environment that those things need to have some stomach acid for absorption. They also affect the parietal cells. The parietal cells produce hydrochloric acid, and they tend to shut those down. Parietal cells also produce intrinsic factor, which sort of grabs hold of B12 and allows for absorption. So if you shut down IF, intrinsic factor, not intermittent fasting, but intrinsic factor, you can actually become B12 deficient. So if you're on PPIs long-term, you need to have your doctor follow your B12. And you have to look at your gut microbiome as it may be disrupted.
When you are fasting, should you take the supplements that you've mentioned?
So that's a good question. So there's some debate as to whether, you can take your dietary supplements during the fast, or should you wait till after. Some things may actually interrupt. If you're taking high protein supplementation as a dietary supplement, that may interfere with the fast, but in general, black coffee won't do it. Caffeine won't do it. So those are safe to take. If you're asking if you should be taking quercetin or transresveratrol or metformin while you're intermittent fasting, there's no contraindication to that. But these agents are typically used for people who don't tolerate IF as an alternative, but there's no harm in taking it along with I do. I take berberine and I take metformin while I'm intermittent fasting. It's not been. I also take methylene blue and rapamycin. So
one thing that I worry about is a lot of us are taking multiple prescription drugs, and sometimes it's very hard to find interactions with over-the-counter supplements. Are there any interactions that you're aware of that we should be worried about?
So that's true. There are some engines out there in the cloud where you can plug in all the medications you're on, and it comes up with a drug-drug interaction. Some engines are smart enough to have a few where you can add in things like vitamin D or vitamin E, and they might churn out a report, but there's very few. There are things that we use in our practice that look at herbs and botanicals and supplements looking for interactions. But just get together if you're seeing somebody, and one of our goals is to get people off as many pharmaceuticals that they don't need or are equivocal as possible. Some have to be tapered. You can go cold turkey. For instance, you have to be careful with SSRIs and benzodiazepines. You have to taper those off really slow. Like Cymbalta may take you almost a year to come off of safely, whereas things like statins you can come off of those pretty quickly. When you're dealing with agents that can cause increased bleeding, let's say nattokinase, that's very popular on the protocol, you have to be careful with other agents that can cause bleeding. So nattokinase is a one-way street. The more you take, the more it will degrade fibrin to the point where you could be at risk for bleeding, especially if you're taking aspirin or other NSAIDs, or if you're on Eliquis or some other blood thinner. Whereas lumbrokinase, derived from earthworms, has the same effect against fibrin, but it reaches a point and will turn itself off. And in some cases where there's too little fibrin and there's a bleed risk, it'll actually turn on the fibrin process, making fibrin. So it kind of keeps things in a homeostatic range, if you will. So my preference has always been for lumbro, but I use nattokinase, put somebody on it today as an example. So it just depends. It's very individualized, but realize if you're on curcumin, quercetin, nattokinase, and high doses of fish oil, you might bruise or bleed. So you got to be super careful. You got to be followed by a doctor who knows kind of the ropes.
Is there a length of time that we should be doing intermittent fasting to get a full effect? In other words, a month, 3 months, or just
Right.
until you're better?
Well, if you want to go for longevity and a better quality of life and a better health span, you kind of keep doing it. But I don't know if there's a time. Usually kind of in my experience with Lyme, is you do it and you do it until symptoms are completely abated for at least 1 to 2 months, and then you can slow down. So if you have symptoms and you start out where you're very symptomatic and you start intermittent fasting and you start taking ivermectin and you start doing this and that, until you're at 95% resolution of your symptoms, I would keep going for another month before starting to slow them down. And I wouldn't stop them all cold turkey. I would, peel them away one after another. And the biggest mistake I think we make is we stop therapy too soon. And people relapse and you got to restart it.
Several people are asking about the best treatment for tinnitus or tinnitus, burning neuropathy, and POTS.
Yeah.
I know.
So they're the 3 toughest ones. Probably the toughest is tinnitus. I don't know that there's a solution for that. Some doctors are using high doses of compounded beta histine. Beta histine is a class of antihistamine, and they're using really pretty big doses, BID or TID dosing of that for it. It's been shown with some case studies that it is helpful with tinnitus, but I tell you, that's a hard one to get. It's probably one of the first onset of the vax injured and probably maybe the last symptom to go away. POTS is another one. So there's different interventions. I don't like using the medicinal so much. Like I avoid beta blockers and some of the other agents that have a lot of side effects. The whole licorice, not deglycerized licorice. Licorice is good. A pinch of sea salt in water in the morning is a good intervention. And then some adaptogenic herbs are helpful, but you have to treat the underlying cause. People with Ehlers-Danlos tend to have more POTS. People with CCI, craniocervical instability, do. It's a vagal nerve thing. Almost 50% of Lyme patients will get it. I think that can be said for folks that are COVID illness, whether injected or infected. POTS seems to be a deal with them. And what was the last one? Someone mentioned.
Let's see, tinnitus, burning neuropathy.
Oh, like the small fiber neuropathies. Yeah, peripheral neuropathy is another big one. We see that with Bartonella and some of the co-infections and Lyme, and now, of course, COVID. So again, N-acetylcysteine may be the answer for that, as well as glutathione, if you tolerate and can get IV glutathione. Otherwise, alpha lipoic acid in conjunction with N-acetylcysteine will help your body build glutathione levels in the liver. That might be helpful.
Is there a test for spike protein, not for antibodies, but for actual spike protein? And if so, have you been able to measure a drop in the spike protein by any of these modalities? And which one's most successful?
Right, that was mentioned at the conference. I don't have a handle on measuring spike protein. I think Ryan Cole is working on it with some other researchers. I don't really know of a reliable one that's clinically available. There may be available in research, but not clinically. I tend to not rely on biomarkers. That's been a big disappointment, is some of the biomarkers of inflammation. You can run a whole panel of 30 of them and they all come back normal, but the patient looks like, they're a hot mess. They're a train wreck. And you can't go and say, well, all your biomarkers are negative. You heard that before. It's all in your head kind of thing. So you have to look at what's in front of you clinically and say, the best biomarker might be what's coming out of their mouth. And I routinely ask them to grade their condition upon arrival on day 1 and where they are now, whether it's 3 months, 6 months out. How do they feel, and quantify that in a form of a percentage. I'm also looking at a questionnaire, much like Dr. Horowitz's MSIDS questionnaire. I've taken that and morphed it into one to be utilized for grading or diagnosing clinically COVID illness stuff, like long haulers or vax injury. It turns out to be very, very close to the original 38-point questionnaire. So there's a lot of overlap. People say, well, how do you distinguish between mycotoxin illness, Lyme disease, and COVID? spikopathy, and it's sometimes very difficult. You have to sometimes run some serology tests or do a deep dive in their history to find out, if they've not been vaccinated, well, that's probably not spike unless they've been infected 3 times, So, so that you should have to, if they're up from the Northwest, if they lived in Vermont and were hikers and pulled 5 ticks off a day while they were a youngster, well, you got to consider Lyme disease, and if they live in a water damaged house, you got to consider mold toxicity. So, but the current list of biomarkers has been really unimpressive to me. So I tend not to run too many.
One person wants to know if you are taking telehealth patients.
Yes, I have a crew of 4 or 5 nurse practitioners and PAs that I personally trained myself, that are very well versed in the FLCC protocols and some of the additional stuff that we do in our clinic, and Lyme disease and mold illness. They're very expert. So if you can't get in with me, getting in with one of them is almost as good. I consult with them on almost every new patient. So I touch all of our patients. But yeah, we do telemedicine in all 50 states.
That's great. Let's see. Is fasting safe for those who are susceptible to AFib, atrial fibrillation?
Oh, that's interesting. I don't know. I don't know the answer to that question. I don't know if it increases risk or not. Although if you have a history of AFib, I would highly recommend. My mnemonic is TAC, T for taurine, A for L-arginine, and C for L-carnitine, TAC for tachycardia. You can also say CAT if you want to memorize it that way. But magnesium taurate, for example, is a good source of magnesium taurine, and that stabilizes the myocardium and makes you less likely to go into AFib. So I don't know if any kind of stress can actually trigger off AFib. So fasting is actually a type of stressor. That's why you have to be careful. And that's why fasting actually can knock the thyroid axis off loop a little bit. So.
Okay. Are you seeing success for any of your clients with chronic vaccine injury headache using Namenda?
So for headache alone, I don't know. Those trials are so early in our center. I mean, we've only been doing this a couple of months now. We have had folks with increased headache, increased seizure activity, peripheral neuropathies all improve. I will say that recently I had a pilot who we started mentoring on, who reported back within the first month fairly significant improvement, not 100%, but about 50% improvement in his neurological and psychiatric issues. But of course, he's also on a lot of other things. So this is not a randomized controlled trial with a cohort taking a placebo. This is just clinical observations, but probably a little too early to tell for sure in a cohort of patients.
This person wants to know about fasting and concern about weight loss. Can short daily 12-hour fasting be beneficial for persons concerned about weight loss?
Concerned about losing too much weight, or yeah, okay. Well, as long as when you eat, and you get enough caloric and nutrition in, so you're not starving. There's a difference between starving and fasting. You just don't want to be nutritionally deficient in nutrition. So you have to eat, foods that are really nutrient dense. So we have in our center a provider that does mostly telemedicine. She's in the office on Fridays in Mount Pleasant, and she's a naturopathic doctor, and she deals mostly with gut and nutrition. I mean, that's her focus. She doesn't really want to go and talk about other things, but she'll do consultations with people to make sure they get the appropriate nutrient-dense foods on their plate every day for every meal.
I just look at it is make sure you get the right amount of calories in per day, whether it's in a shorter period of time or not, but don't cut the calories if you're worried about weight
E-
loss.
Exactly, exactly. Just the time you should be eating, that little window, make sure you go at it and eat the right amount for you.
Let's see. What is your theory on what specifically is causing the ongoing tinnitus? That's a tough one. I don't think
That's
anyone
tough.
has.
I don't know if we know the pathophysiology and what really is going on there.
Yeah.
Because there's, I mean, the spike protein is not the only thing causing tinnitus. I mean, this goes back years and years. I mean, with Lyme patients, there's not only tinnitus, but there's vertigo. So apparently the middle and inner ear are extremely sensitive to insult. So
Another question, have you heard about urotherapy and that urine has fresh stem cells each morning containing urokinase? Wondering if you are doing urotherapy, if there is a certain amount that you should be consuming and how often.
yeah, so that's not in my wheelhouse. I don't know much about it. I've heard of it before. It was mentioned only a few weeks ago to me, but I don't know anything, so I can't really comment on that.
We have a few more questions. What
Sure.
type of neuro problems has memantine been shown to help with? If I pronounced it.
Well, I think the mechanism of action of that drug, its effects on a certain process that goes on in the brain, it reduces or stifles or puts out a lot of neuroinflammation in the glial cells. These are the immune cells of the brain. So by doing that, it's helpful in stemming off any pathology due to neuroinflammation. And that's at the crux of it. I mean, neuroinflammation is what's causing this problem, and maybe a prion effect. I mean, there's talk, if you were there for the conference and listened to Dr. Suzanne Gazda talk about prions and prion disease and neuroinflammation, and Pierre goes on about neuroinflammation as well. That's where it is. And if you can put out that fire, a lot of the neurological stuff goes away.
This person is asking about dysautonomia and extreme insomnia. Is there anything to help this?
Sure. So insomnia is one of the chief complaints. You know, you've got fatigue, you got brain fog, and insomnia. The pilot I mentioned earlier, he was almost suicidal because he went a whole year before he came to see us, going to different specialists, and nobody could cure his insomnia. Well, we managed to, using trazodone and letting him titrate his dose for effect. He finally, after weeks and weeks of going with only 2 hours of sleep every night, became extremely frustrated. His brain fog was tremendous, and it got to him to the point of he almost wanted to take his life, and that was scary. He called, our nurse called him back in a few days because we were really worried about him, and he was beaming with joy because he had finally gotten 8 hours of sleep, and he was like a new person. And 50% of his problems that he complained about on his first visit completely ameliorated. So we were halfway there with him after getting him his sleep back. Now he uses trazodone just periodically. He uses a combination of CBD, CBG, and Delta 8 at times to help with sleep. And then we wound up diagnosing him with Lyme. He went through a Lyme treatment, and within 5 months, he was almost at 90% better. And, that was a big success case. And I was really worried in the very beginning. I thought, this guy, he's going to take himself out before we get a chance to start treatment. But praise God, he didn't. And thankfully, he's his wife was standing on the telemed. His wife was standing behind him, jumping up and down, saying, no, it's 95% better. And he was grumbling about the last couple of percentage. I said, you should be grateful that you're beyond 85%. But he was a good success story.
What dose did he end up titrating up to on the trazodone?
150 milligrams. Now he just started methylene blue. I think he's up to maybe 8 drops now. When I talked to him last, he was at 5 drops, and we titrated him to 8 drops BID. He's photobiomodulating. We did start him on Namenda, so he'll be one we'll follow. So he's in our group we're following for methylene blue and mementine. And I'm trying to think of what else. We've actually taken away a few things that he doesn't need anymore. Like I think we took away the spermidine. He's on NAC still, but his protocol shifted and we added some new things, and we took things away that were maybe not so effective or he didn't need anymore. So you have to be careful as practitioners out there not to increase the pill burden to where it gets too crazy.
Two more questions. What are your
Sure.
thoughts on hyperbaric oxygen for nerve injury from the vaccine?
Well, I've seen it work about 50% of the time, whether you're dealing with nerve injury or brain fog or whatever. It's not for everybody. There's soft shell, hard shell. There's different protocols you can follow. I haven't seen too many with great success that have come into my center. I don't do hyperbarics in my office, nor do I do ozone. But what I've seen from both of those is that it's about a coin toss. If you can afford it, and it's not going to empty your bank account, then go for a series and see if it works for you. If you do a few and it doesn't work, it's probably not going to.
I know it makes some people worse, so you have to be careful.
Yeah, that's with everything, even LDN, low dose naltrexone. And I was really impressed when Joel put up a slide showing the best interventions from a poll that you guys did on your folks. And I want to say, I think LDN came in at the top.
Right.
Yeah.
LDN and intermittent fasting for me have been a game changer.
Yeah.
One last question. Have you had any experience with nicotine patches?
Yeah. So there have been, tossing around the idea of using nicotine, not vaping and not smoking cigarettes, obviously, but in the form of either the gum or the patch to help with neurological COVID or long haulers. I have not used it in the vaccine-injured. It's on some of our protocols at the bottom of the list. I don't think too many people have embraced it too much. I just don't use it, but I know it's out there. I know there's anecdotal evidence that it helps. What's been your experience? Have you done any?
I've just been reading about it, but
Yeah,
I've been tempted to try it, but
yeah.
I haven't.
Yeah, I put it on a protocol, our list of things to consider, but I don't think me or any of our practitioners have actually jumped in with that.
I'm going to ask you one last one and then we'll let you go. Do you
Sure.
ever suggest choline or inositol for nerve pain?
Yeah, so inositol, choline, sure, they may be helpful. There's another agent I should mention because I'm updating my protocol. Guanfacine, which is an older ADD, ADHD med. There's a call for using 1 to 2 milligrams nightly of that with NAC. That might be helpful. Also, cryptolepis, which is, we use that a lot in Lyme. That may be helpful in some of the vaccine-injured. And GABA, which is a neurotransmitter, one of the two calming neurotransmitters, 500 to 700 milligrams nightly, or even BID, even twice daily. And then there's a product called NeuroPX from what's it called? Restorative Therapeutics, I believe, is the company, and it contains Tudica, TUDCA. It's a type of acid, fatty acid, organic ashwagandha, nicotinamide riboside, or NR, and thiostilbene. It's a combo of those 4 agents. You take 2 to 4 capsules a day. That may help a lot with the neurological stuff. Now, what was the agent you had asked me about for neuro?
Well, choline and inositol.
Oh, choline and inositol. I don't use those as standalones. Usually they're in something I'm prescribing. But yeah, the choline, the brain needs that. It's in yolk. The yellow part of the egg is a good natural source. So I encourage people who aren't allergic to eggs to eat eggs. They're a great source of protein, and they've got choline and inositol and all that good stuff in them.
A couple more just popped in.
Sure, that's okay.
Okay. Thoughts on gabapentin to break the supposed pain cycle? I'm in nerve pain in left perineal nerve.
Sure. So I refilled the gabapentin prescription today, so I do use it. I usually refill those patients who have been placed on it by another provider. I'm not a big fan of gabapentin or Lyrica, but I will prescribe them on occasion, but not long term. I do not write for Cymbalta. I think that's a very dangerous drug, very difficult to come off of. And if you go cold turkey or you run out, you could have a seizure. I witnessed that on a vacation. A young lady ran out and didn't have her Cymbalta for 5 days, and she was seizing. I had to put on my doctor hat and give her first aid while I was on vacation. And come to find out, it was the Cymbalta withdrawal that caused her seizure. So I don't like that drug at all. I call it Cymbalta. I don't think it should be on the market. But you have to be careful with some of these pretty potent drugs, albeit they've been around a while. They still have a lot of adverse side effects. But I will use it temporarily.
Yeah. This is the last one. I
Sure.
have had a semi-paralyzed right leg since my AstraZeneca vaccine for the last 17 months. Other than physiotherapy, what can I take? I'm in Melbourne, Australia.
Goodness gracious. Well, ivermectin might be a good idea. Mementine, definitely. Methylene blue. I would consider rapamycin. I don't know the availability of all these in Australia, even ivermectin. I would definitely consider glutathione IV, but be careful if you have a lot of heavy metal toxicity. This person needs to be followed by a functional medicine doctor. I have taken people in wheelchairs and on walkers, and they are walking again within 3 to 6 months. But you have to work diligently, and you have to keep prescribing the right kind of stuff. You got to support the mitochondria. I don't think you should just throw up your hands and say, well, I'm going to be relegated to a wheelchair for the rest of my life. I've seen some amazing things happening with MS and ALS patients when the underlying diagnosis, this is years ago, was Lyme disease. So that person should also be checked for Lyme and make sure that they don't have a concomitant Lyme infection that's causing them to be to lose the use of their leg.
Well, I think we'll let you go. Thank you so much for this wonderful talk. You've really given us a lot to think about. And I'm sure your phone is going to be ringing with a lot of people wanting to see you.
Sure thing.
Thank you
And
so
we're here
much.
to help as best we can. For those I'm with financial issues, I know there are some folks that are crushed financially because of all the medical bills and maybe not being able to work. We do some pro bono case, but we get so many that they go into kind of a raffle lottery thing, and we draw 2 names a month to do some pro bono. So don't lose hope, keep plugging away, and hopefully you'll see some results. It may take some time.
Thank you again, Dr. Saleeby.
Sure thing. Glad to be here.
Very well. Bye-bye. Bye, everybody.